I'm James Hamrick. I'm a medical oncologist and chair of the Precision Oncology Alliance at Caris Life Sciences. And I'd like to discuss an ASCO 2025 abstract. This was a cross-institutional study involving a number of different institutions led by investigators at Memorial Sloan Kettering Cancer Center. And this looked at Epstein-Barr virus-associated gastric cancer. Gastric cancer is already a fairly rare tumor. The cohort of Epstein-Barr virus-associated gastric cancer is about 9% of overall gastric cancer cases and is associated with a unique immunophenotype. In this study, we were interested in the impact of immune checkpoint inhibition in this cohort of patients. This study sought to clarify the outcomes of this across the 9 tertiary cancer centers to look at whether next generation sequencing, where we're looking at molecular sequences, can replace the in situ hybridization legacy testing method, which had been the gold standard for detection of EBV-associated gastric cancer. So this was a retrospective study looking at patients with metastatic Epstein-Barr virus-associated gastric cancer. It stratified patients receiving immune checkpoint inhibitors alone or with chemography. The authors looked at progression-free survival and overall survival. Using the NGS, a total of 91 patients, so a fairly rare tumor. That's a pretty good sized cohort. All had received immune checkpoint inhibitors in the metastatic setting, were included. Most of the patients were from the United States and Asia. And what we found is that the EBV-associated gastric cancer can be reliably identified from next generation sequencing, which negates the need for costly in situ hybridization testing. Furthermore, patients with EBV-associated gastric cancer actually do achieve a high overall response rate on immune checkpoint inhibitors with or without concurrent chemotherapy. Even among those patients with EBV-associated gastric cancer, there is immune heterogeneity. And so we saw patients who had a PD-L1 CPS score of greater than 5 actually derived better checkpoint inhibitor benefit. So this opens a lot of questions related to looking at patterns of disease progression in this cohort, this sub-cohort of gastric cancer patients who are treated with immune checkpoint inhibitor therapy. I think there is definitely an opportunity to educate oncologists about the appropriate use of NGS testing. It's an incredibly nuanced and complex field, and it's only growing more nuanced and complex as the science advances. I trained as a medical oncologist and have practiced for many years, and you actually don't get the level of deep understanding and fluency in molecular medicine in your medical training. So it's hard to keep up. We have something like one new oncology-related FDA approval or label expansion happening per week. It's really overwhelming, especially for general medical oncologists such as myself. And so understanding where and when to use these amazing tools that we have of NGS sequencing and whole exome sequencing, whole genome, whole transcriptome is really important. And one of the things that I talk about is much in the same way that we lean on clinical pharmacy specialists because polypharmacy is such a big deal in patient care. So we know that we have these doctorate level experts. It's really important to have access to a molecular expert as well. And we see, and more practices are doing this through pathology, through some of the testing vendors. And I think that's incredibly important because we're subdividing what used to be fairly common tumors into smaller, more rare tumors based on tumor biology. And that's a great thing because we can drive better outcomes. But it's really hard for oncologists to keep up and make sure they're using these tools to the maximum advantage of the patient. As with many things, when it's hard for even experts like medical oncologists to keep up, there's a big risk of driving inequities in care. And so it's very important that we stay abreast and leverage resources to make sure the right test gets done at the right time. And not only the right test, the interpretation of the test and actioning on the appropriate therapy as well. So there are a lot of potential points of failure in that chain of making sure that everyone benefits from all of this wonderful new technology. And it's incumbent upon the entire system to set doctors and patients up so they get full advantage. Especially in rare diseases, it's really important to have collaborative studies where we're pooling data resources from different institutions. So I love seeing things like 9 different institutions coming together to look at EBV-associated gastric cancer because even big institutions often don't have enough patients in them to draw meaningful conclusions for rare tumors. So I love instances where institutions band together and share their data and do it in service of answering questions for rare diseases that are really hard to address at a single institution level or in small data sets.